It's 11:47 at night, and the pain is strong enough that sleep is no longer an option. You sit on the edge of the bed with your phone in one hand and your health insurance card in the other. The card is supposed to be the reassuring part. You pay for it every month. Maybe it comes out of your paycheck before the money even reaches your bank account. You did the responsible thing. You are insured. And yet the first question in your head is not, "What's wrong with me?" It's, "How much is this going to cost?" You search for urgent care. Closed. You search for the emergency room. Open. Then comes the second search. Emergency room cost with insurance. Then your deductible. Then your plan app. Then a PDF with 12 pages of words that somehow make the pain in your stomach feel easier to understand than the price of walking through a hospital door. This is the strange part of American health insurance. The product is designed to protect you from medical costs. But for a lot of people, having insurance does not remove the fear of using healthcare. It changes the fear. Instead of asking whether you have coverage, you start asking what your coverage actually means tonight. For this doctor, at this facility, for whatever test they decide you need. And the answer may be completely different from what you paid last time. Health insurance is easy to misunderstand, because most of the things we buy work in the opposite way. You pay for a movie ticket, you get the movie. You pay for a meal, you get the meal. You pay for a streaming service, you open the app and watch. Insurance is not prepayment for healthcare. It is a contract that decides how the financial risk gets divided after something happens. That difference sounds technical, until you are the person deciding whether the pain is bad enough to spend money you cannot see yet. Start with the deductible. If your plan has a $2,000 deductible, that does not mean every service costs $2,000. And it does not mean insurance does nothing until exactly $2,000 has been spent. Plans vary. Some services can have copays before the deductible. Preventive care is treated differently. But the basic idea matters. You can pay premiums all year and still be responsible for a meaningful amount of your own medical spending before your plan begins paying more of certain covered costs. For workers with employer health coverage, the average annual deductible among people in plans that had a general deductible was $1,886 in 2025. About a third of covered workers were in plans with a deductible of at least $2,000 for single coverage. And for people buying coverage through the Affordable Care Act marketplaces, 2026 became even more dramatic. The average deductible across marketplace plans rose to $3,786, more than $1,000 higher than the year before. Now go back to the bedroom. You have insurance. You may also have rent due next week, a car payment, groceries, a credit card balance, and a checking account that was not built for a surprise bill measured in 4 digits. Suddenly, should I get this checked? Is no longer a purely medical question. It is a household budget question with a body attached to it. This is not just a theoretical fear. In KFF polling, more than 1 in 3 insured adults said they had skipped or postponed healthcare they needed because of cost. Insurance dramatically changes the risk, compared with having no coverage, but it does not create a force field around your bank account. And that leads to the first contradiction. The moment when insurance is most valuable is often the exact moment when you have the least mental space to understand it. When you are healthy, you can compare premiums, deductibles, copays, coinsurance, drug tiers, networks, and out-of-pocket limits. When you are sick, you want one answer. Can someone help me? And what is this going to do to my finances? Instead, the price can depend on several moving pieces at once. Which facility you use, whether a provider is in your plan's network, what service is performed, how the service is coded, how much of your deductible you have already met, whether the plan charges a flat copay or a percentage through coinsurance, what the insurer's negotiated rate is, and whether there are multiple bills from different parts of the same episode of care. There are federal protections that have reduced some of the worst forms of surprise billing, especially for many emergency services and certain out-of-network care at in-network facilities. But those protections do not turn American healthcare into a fixed-price menu. Even when a bill is completely legitimate and covered exactly according to the rules, the amount a patient owes can still be difficult to predict before care happens. That uncertainty changes behavior. Think about 2 doors. Behind the first door is a doctor visit that definitely costs $50. Behind the second is the same doctor visit, except the price could be $50, $200, or much more depending on what happens after you walk in. Even if the average cost behind the second door is manageable, the uncertainty itself feels dangerous when your budget is tight. This is the midpoint of the story. Because the problem is not simply that American healthcare is expensive. The deeper problem is that the patient often has to make the medical decision before the financial outcome is fully visible. That is a very unusual way to buy something important. You would not agree to a major car repair without wanting an estimate. You would not hire a contractor and say, "Do whatever is necessary. Send the details through a third party, and tell me my share a few weeks from now." But healthcare is different, because sometimes waiting for perfect price information is not realistic. The thing being purchased is not optional convenience. It may be relief from pain, a diagnosis, or treatment that becomes more urgent with time. So the person in the bedroom starts negotiating with himself. Maybe it will be better in the morning. Maybe urgent care is enough. Maybe the pain is not that serious. Maybe the doctor will just tell me to rest. Maybe I can wait until my primary care office opens. Maybe I should not turn this into a $1,000 night. Notice what happened. No insurance company had to deny anything. No hospital had to send a bill. The possibility of an unknown loss was enough to become part of the medical decision. That is where the ancient wiring comes in. Human beings are not neutral calculators when we face uncertain losses. A known cost can be unpleasant, but an unknown cost creates a different kind of tension. Your brain starts searching for ways to avoid the threat altogether. Behavioral economists call one part of this ambiguity aversion. When outcomes are unclear, people often prefer the option where the risk feels easier to understand. Add loss aversion, the tendency to feel potential losses especially strongly, and wait and see can begin to feel emotionally safer than opening a door with an invisible price tag. The body is saying, solve the health threat. The bank account is saying, avoid the financial threat. And the same person has to make both decisions at the same time. This is why the insurance card can produce such a strange psychological effect. It represents protection, but it also represents rules. The card means you are covered, but covered is not the same as free, and it is not the same as predictable. It means there is a system standing between the full medical charge and what you ultimately owe. That system can save you from catastrophic costs. It can negotiate prices you would never want to face alone. It can cap certain covered in-network spending. But it can also leave you trying to calculate your personal exposure while you are already stressed, sick, or scared. And in 2026, that anxiety is colliding with higher costs for many households. Nearly 2/3 of American adults told KFF they were worried about being able to afford healthcare for themselves and their families. Among returning marketplace enrollees, surveyed early in 2026, 8 in 10 said their premiums, deductibles, copays, or coinsurance were higher than the year before. About half said they were a lot higher. Those numbers matter because the fear does not stay inside a spreadsheet. It changes ordinary behavior. A person delays a scan. Someone stretches a prescription. A parent waits another day before making an appointment. A worker tells himself the pain is probably nothing because the deductible resets every January, and he has barely spent anything toward it yet. Not every delay becomes a disaster. Many symptoms really do disappear. But the financial incentive and the medical incentive can point in opposite directions, and that is a dangerous conflict to normalize. There is another reason this feels so personal in the United States. For millions of people, health insurance is connected to employment. The insurance card in your wallet is often part of your compensation. Your employer may pay a large share of the premium. You pay another share. Then, you may still pay a deductible, copays, coinsurance, and other out-of-pocket costs when you actually use care. So when someone says, "But you have insurance," they may be describing something real and still missing the experience completely. Yes, insurance matters. A lot. Going without it can expose a person to much larger financial risk. But the emotional promise people hear in the word insurance is often simpler than the contract itself. The promise sounds like, if something goes wrong, you are protected. The lived reality can feel more like, if something goes wrong, you are protected from some risks, according to a set of rules. And you still need to figure out what portion of the problem belongs to you. That gap between the simple promise and the complicated reality is where the fear lives. Back in the bedroom, the clock is now after midnight. The pain has not gone away. The insurance card is still on the bed. Nothing about the card changed in the last 20 minutes. What changed is your understanding of the decision. The card was never a pass that made healthcare free. It was a shield against a much larger financial threat. And shields are valuable. But this one has gaps, conditions, and a price structure that can be hard to see from behind it. Eventually, the question becomes impossible to avoid. What is the point of paying for protection if using that protection still feels like taking a financial risk? The answer is uncomfortable because both things can be true at once. Health insurance can protect people from enormous medical costs, and insured people can still be afraid of the bill. The system does not have to fail completely to change behavior. It only has to make the next loss uncertain enough that waiting feels safer. And that may be the strangest part of getting sick in America. Before you know the diagnosis, before you know the treatment, sometimes even before you decide to walk through the door, you are already doing math.